Hey there, Whitney.
Hi.
So what we're going to do is we're going to do an orthotic scan today. It's going to check for pronation, or if the feet are angled and how that may affect the ankles, the knees, the hips, the pelvis, and then how it even affects the spine in general as well, and if there's a need for spinal pelvic stabilizers. So what we're going to do first, we're going to have you stand onto the scanner here.
Okay.
We're going to put your right foot right on the glass on the window.
Right here?
And left foot right to the side, yeah.
Okay.
So what it's going to do first is there's going to be a little laser, and the laser's going through right now. We can see. The laser's going to check for topography and the depth of the arches. And the second scan is going to come through, and it's going to tell us the pressure and sensitivity on the bottom of the feet and where you're actually standing, and if there's pronation or supination, where the arches are dropped as well. And then it's going to calculate that, and then we're going to switch to the other foot in just a second. So we're going to put your left foot right on the window now, and the right foot to the side. And now again, it's doing the same thing. The laser is coming through and it's checking the topography, which is the depth of the arches. We have 3 arches in the foot. We want to make sure that we maintain them all. If one's maintained and another's not, that means the foot is everted or inverted, it's pronating or supinating, and that can affect, again, the feet, foot pain, but then also can travel right up the kinetic chain to where we have ankle, knees, hips, pelvis, or even spine can be affected when not properly stabilized. So what we see here with the scan, on this side we see what a normal sample would look like, and over here we see what our patient's actual scan looks like. So what we see with the normal, the red is the most amount of pressure, then yellow, and then green, and then blue. So we see in this area here on the ball of the foot we should have a lot of pressure. Same thing down here at the heel. We have 3 arches here, this lateral arch, this medial arch, and then the transverse longitudinal arch through here. And where we have that, we call that the plantar vault. And where that vault is, we should have very little pressure. There's 3 arches there to support. And so we could see with hers, and we'll turn it into color in a second, we're going to see that she's missing the lateral arch, or the outside of it. Her medial arch is intact, but the lateral arch is missing, meaning she's pronating the feet. And with that, we can see actually what it's doing to her pelvis. We can see that it's tilting the pelvis, it's torquing the ankle, rotating the knee in, torquing the pelvis this way, and dropping the shoulder on the opposite side down. So again, you can see here that these lateral arches are now missing here. We see still she's maintained some of the medial arch in the green area here, but you see even at the toes, excess pressure past the ball of the foot to the toe, and then this whole outside arch here. We're going to see now as it's going to turn, we're going to see what it looks like on the outside. And we're going to torque some of these angles so you can see exactly what her scan looked like. This is the posterior, the back of the foot. We're seeing the actual heel itself here. And this is going to show us, we're going to look at the actual arches. And what we can see with hers is that her 2 arches, even though she does have some medial arch, the 2 arches are actually different. So you can see as I'm pointing the mouse here, the one arch on one side is a little lower, this one's a little deeper. So she's walking on 2 different feet, and what that's doing, that throws the whole pelvis out of alignment. That changes up the kinetic chain. So from the ankles to the knees to the hips to the pelvis, throughout the kinetic chain is different. So as we turn them to the side here, we're going to see, look at the actual arches themselves here. They're different from side to side, so it's affecting everything. So she would be a great candidate for spinal pelvic stabilizers, and what those would do is help her hold her adjustments better and support everything from the bottom of the kinetic chain up. You can see here there's a significant amount of force that enters in the heel strike, moves up the kinetic chain to the knee, to the hip, and up to the spine, and literally still 10% of the total force from that heel strike is actually still hitting her right in the neck. And so it's actually contributing to some of the problems she has with her neck, middle back, and lower back as well, not only pain on the bottom of the feet or the plantar fascia. So we do use these products to go along with our chiropractic care, again, to help people hold their adjustments and help just support the arches and prevent injury, prevent ankle injuries, foot injuries, knee injuries, hips, and even spinal injuries as well.
So I'm Dr. Neil Rodnick. Dr. Adam asked me today to come in and show you the kinesiotaping for the foot arches. And what these are going to do is actually, it's similar to the foot leveler thing, only a little bit more of a gentle way of doing it. And we're going to put 2 pieces of tape per foot here, and it's actually going to bring the 3 arches back a little bit. And this kinesio tape can be used all over different joints in the body as well. It's either used for stretching or for tightening up muscles and ligaments and kind of adding some more support. Bring your foot toward me. So what we're going to do here, this first one we're going to tape across the metatarsal heads. And we actually leave it nice and loose, and then we kind of stretch the top part and bring the bottom together a little bit. And the second piece we're going to bring in and go straight across the navicular bone. And same thing, going nice and loose, and then we're going to tighten it up at the bottom and stretch the top. Do both feet. And with the soft kinesio style tape, when you do these, you really won't be able to tell anything's happening at all until you're standing up moving around on it, and then you'll actually feel it pulling the arches in a little bit. And that's it. So the 2 pieces of tape are going to kind of bring back some of the lateral arch, the medial arch, and the transverse arch into the foot. And I'll show you what stabilizing orthotics actually look like. So if we decide to incorporate these in your care, we'll show you what they look like and what their purpose is and what they do. So here, this is a 3/4 length. And what I like about this particular company, or this particular brand that we use here in our office, is that we can customize it to some degree based on the type of shoes you wear the most, and the type of activity level that you do the most as well. So you can see that this particular one is 3/4 length. It's not quite as long. It's not going to go the full shoe length here. And see, this type of a material here is best for, let's say, dress shoes. You know, it's not too hard, not too soft. If you feel it, it's got a little bit of a give to it. Yeah. And what this does differently than, let's say, an over-the-counter orthotic that you may find at a local drugstore or a sports store or something like that, is most of those only support 1 arch. What these do, because again they're custom, it's going to go based off the scan that we did with the laser. Here, it's going to send it right to the lab electronically. The lab will use that to make a mold, to make a custom orthosis for you. And it helps support the entire plantar vault, which is 3 arches. Again, the medial arch, the lateral arch, and the transverse longitudinal arch. And it supports that whole vault, which that whole vault actually supports your whole framework, your whole structure, all the way up and down. Again, from your feet to the knees to the pelvis, up through the spine as well. So it supports a lot more bones and joints than you would actually think, because you're constantly standing on it. We need that full proper support to stabilize the pelvis and the whole body. So again, this is a 3/4 length. If you wear a lot of high heels, we can make it a little thinner. You can see the thinner ones here, we could put a Velcro strip in it like this so that it sits into a high heel. They make it custom for a 1-inch or a 2-inch high heel. This type of material here is more waterproof, a little harder, more durable. A lot of the times firefighters, somebody's on their feet all the time, need more toughness to it. We'll use that. And this one we have like a sweat absorbent material here, and the sweat absorbent material is more custom towards athletic shoes, working out, things like that. It's got sweat absorbent and moisture wicking, things like that as well. There's a few other things we can do to make it more customized. Let's say you had a heel spur, we can put a little cup in there to avoid putting pressure on the heel spur at all, or sorts of things like that, to make it a little more softer on the impact, on the heel strike as well, things like that. So I'll give you a little pamphlet just kind of going over the difference between a custom spinal pelvic stabilizer or just an over-the-counter insert that someone may find, at the checkout counter at Walmart. So you can take that with you and let us know so we can customize something that will also help your adjustments hold a little better and help things stay a little longer for you, spine and pelvis-wise as well.
Hi there, welcome back to Ask the Chiropractor. I'm Dr. Adam Rodnick out of Commerce Township, Michigan. We're here with our co-host.
And I'm Dr. Ruben Rubenstein out of Troy, Michigan.
And our special guest returning, Dr. Michael Kopsikavathis out of Birmingham, Michigan, orthopedic spine surgeon.
Thank you, guys. Nice to be here.
So let's just talk about for a minute what we just saw, the video that we had playing from the clips in the office. We talked about how the bottom of the feet, the arches, there's 3 arches, the medial, the lateral, and the transverse longitudinal arch. And if we don't have proper support while we're walking around, weight bearing all the time, it can really throw off our ankles, our knees, our hips, and it can even affect our spine. By overpronating the feet, it can make a big difference in spinal joints, again, hip joints, knees, all the way up and down the chain. And by doing that with all that extra wear and tear over time, it can potentially cause degenerative changes, can cause misalignments. And so one thing that we do in the office is we could do a scan, check how the bottom of the feet are. If the arches are great, awesome. If they're not, we can send it out to a lab. They can make a custom orthotic for the shoes to really help balance and stabilize the bottom of the feet.
Dr. Michael, I know you're a orthopedic spine surgeon, but I'm sure you trained in the extremities as well. Did you notice how extra pronation or supination of the feet can go up the kinetic chain and affect the spine?
Absolutely. I have the problem myself. I get over it by using a specific variety of high arch shoe. When I stand for certain operations, there's times when I'm standing for 12 hours straight for a complex spinal reconstruction. So let's just say I don't wear regular jogging shoes. I'm very cognizant of it. I see a lot of the effects of it late, and misalignment that comes through the knees into the hips, and especially if it's on one side worse than the other, then you can see actually the pelvis being thrown off. And as everybody else knows, scoliosis is not exactly good for you.
Yeah.
And so I see it in my practice, yes.
Yeah, I see it more and more patients these days. They come in and they have back pain, and I'll x-ray them and I'll say, did you know you had a 30-degree curve scoliosis? Like, oh, I remember in middle school they did a check on me. They told me I had scoliosis and they sent me out of the room with a piece of paper. And I said, what did you do about it? They go, well, they didn't tell me to do anything about it. Now this is 25, 30 years later, and these people are walking around and they say, oh, you know, I think, yeah, they tell me, oh yeah, I had that in middle school. But we need to make sure we get to the root of the cause, which could be the overpronation or supination of the feet, going up that chain, causing the imbalance of the hips, going up the spine and causing the curvature to change. So if we got to this when they were in middle school and didn't wait 20, 30 years till it's already 30-degree curve, we could help correct these or even help start reversing them.
And we see it goes the other way as well. Someone has a pelvic misalignment, what it does is it could pull up on the leg. We see that one leg may be a little shorter than the other. And a lot of times through chiropractic adjustments of the hips, of the pelvis, we can balance out those legs. Other times there may be congenitally short legs, whether it's, you know, someone had an ankle surgery, or, and myself, I had an ankle surgery, broke my ankle through the growth plate when I was in 9th grade, so I have one leg a little shorter than the other. So I have custom orthotics with a little bit of a lift in one side just to help balance that out, so it's not affecting my knees, my hips, my pelvis as well.
So tell us how you got into your field of work. What brought you into becoming an orthopedic spine surgeon?
I always knew I wanted to be a doctor, but the picture that I had in my head initially was not a spine surgeon. I honestly wanted to be a small town family practitioner, get paid in chicken feed and ham. And somewhere in there I fell in love with the deep, complex anatomy and physically going in and fixing things. The family practitioner has a tough job nowadays in that it's so much medication, and they have so little time to talk with their patients. It's just a tough job, and I met a lot of people that were dissatisfied with it. And between that and realizing I wanted to just go in there and fix things, I did orthopedic surgery instead. I get to play carpenter of the human body. My mother is a spine patient, and it was the one thing I said I could never do. And so, of course, it became the one thing that I am completely passionate about and could never do anything besides that. So she had failed spine surgery by, quite frankly, probably the most famous spine surgeon in America. It just became a calling, and I read about it, I think about it, I invent new products. I can't escape it now.
Yeah.
But I love what I do, so.
I mean, we want to let our audience know, just because you said the best spine surgeon in America failed, it doesn't mean you should stay away from
Right.
Dr. Michael. It doesn't mean that means everyone's going to fail if the best does. People have more success rates than others. I mean, you never know if anyone would have failed on that surgery or not. So I just want to let our audience know that just because the best in America failed doesn't mean that you should not go if we refer you to Dr. Michael.
Well, let's talk about the training, right? You know, a lot of people may think, you know, you went to medical school, then poof, you're just doing spine surgeries. There's a lot in between there.
Correct.
Residency, fellowship. If you can kind of explain that, like how much time, hours, training before you were just let loose.
Yeah, I suppose we could start with medical school. After a 4-year degree, I spent in biology, bachelor's degree. Medical school, the average semester people take classes in college is 12 to 16 credit hours a semester. It's 32 credit hours per semester in medical school. So basically, for 4 years, you do 32 credit hours. It roughly equates to somewhere between 60 and 100 hours a week worth of class and studying, and for some people a lot of crying. But that's 4 years of medical school. After that, you do residency. Internship is just the fancy name for the first year of residency, effectively. I'm trained as a DO, and through the Michigan State system, I learned all variety of orthopedic surgery. That's 5 years, so now we're at 9 years. 13 if you count college. And after my 5 years of orthopedic surgery training, I spent some additional time in Boston doing 100% minimally invasive and complex spine surgery, which is where I truly perfected the craft, I suppose you could say. And it's called practice for a reason. It's always should be a evolution of becoming better. And the reason I brought up my mother's failed spine surgery is because one of the obvious problems with my profession is it needs help. It needs to be better. There is so much work that can be done. There are people that we can't understand why they should have gotten better. Why didn't they get better? Why didn't they get
the results that they were
the
looking
results
for.
that they were
You
looking
can't do
for?
too many double-blind studies in your profession. You know, it's not like
You
just-
can't. Correct.
like you can with a medication, a placebo. You know, it's a
Correct.
surgery, so it's very hard to have the constant chronic research, right?
Right. So you just several drops of prudence and talking with your patients, trying to get them to understand what to expect, and simply being conservative and caring and applying the test of this. If this were your sister, what would you do for them? And I love what I do again, but there's work that needs to be done, and that's why I'm all about minimally invasive techniques and non-surgical stem cell injections. All of those are things that need to at least be considered before you jump in and rods and screws and all that. So.
Love that. And a lot of people have misconceptions with us as well about our schooling process. People don't realize that, you know, our chiropractic degree, it's a doctorate degree as well. We have, you know, 4 years of undergraduate, 4 years of graduate school, and a lot of people don't realize the first couple years for a doctor of chiropractic degree is basically the same as DO, MD, podiatrist. You know, our first few years we're taking
all the sciences.
Exactly. We're taking
Biochemistry.
neurophysiology and gastroenterology and all sorts of genitourinary and different classes like that, things that we really will never deal with or encounter, but it's a knowledge base that we're able to know about and be able to refer patients if they ask us questions or let us know about their health concerns.
I'm not a surgeon, but I did have to deal with a cadaver and learn the ins and outs of a body with a scalpel. And I mean, the patient wasn't alive, and I had no failure rate. He was already dead, so it wasn't like I could
Couldn't really
mess
mess
anything
up,
up.
yeah.
But we did have to learn all the anatomy the same exact way with cadavers in front of us in the gross lab, and we had to learn about all that stuff. But I mean, it was basic. We didn't have, after we finished, I mean, you went on for 5 additional years of training to learn to make sure that you're a master in your skill. And we appreciate that because, like you said, the world is evolving, and we got to keep up with that. So there's always new things coming out. So I'm glad to know that there's doctors that we're having right here on our show that are evolving with that time. finding new things, making sure that if his mother had to go back, it's going to be successful this time. Is that correct? I mean,
Yes,
that's
sir.
what it's all about. We want to make sure that we get the results.
And what I like about your approach, what you're saying, is that you start with minimally invasive spine surgery if they're prudent, if it's applicable, and if that doesn't help someone, you can always go for the more invasive surgeries. Is that correct?
Correct. There's a lot of steps between pure conservative care and rods and screws. There's a lot
Right.
of, and
Love that.
one of my passions is develop more, because while there are some things there, there's not a lot of things there. And it's important to find more options that fit exactly where somebody is at. For some people, there are no good options besides complete reconstruction, rods and screws. There's no other way around it, but for some people, what's ideal for them is far from that. And sometimes it's surgery, sometimes it's injection. But to go back to what you said earlier, I love that we can communicate. And that has to do with the fact that you guys work the musculoskeletal system every single day in your lives. You try and communicate it to your patients, explain to them their own bodies, and that's why working hand in hand is natural between an osteopath and a chiropractor, because that's what we do. We have a whole holistic understanding of the human body. I understand that I use a scalpel, and you guys have your cool tools that I have no idea about, but at the same time, we're going back to speaking the same language, understanding the pathology, and the trainings overlap massively in that way.
And like you said, there's no reason not to go up the chain. I always tell our patients, it never hurts to start conservatively, move on to drugs and surgery, but I love that you're almost adding an extra step in the chain with minimally invasive surgery between our conservative care and the rods and screws. And so, unfortunately, we see a lot of patients that came into us already missing most of the boat. They started off, they had chronic pain for a long time, never really sought care, never really had a consultation with anybody. They come to us, they already are into the rods and screws stage, and they totally missed the whole conservative side, missed the minimally invasive side,
Yeah.
went right there. And so again, we mentioned this last time, I always just encourage people to have a consultation. Find a doctor that you trust, that you can just talk with and start a rapport with, start a file with, and be able to manage your spine or your care or your case over a lifespan, rather than waiting until it's so bad where you have to do something. You're in the ER and you have no choice but to do something right now.
Yeah, that's a sad situation when somebody shows up, like you said, shows up at the emergency department, basically unable to walk. And whatever their pathology may be, we kind of shake our heads and we're sad, but it is what it is. And at that point, it's hard to offer them anything besides severe problems, severe solutions to severe problems. So preventative medicine, everything from shoe lifts to exercise, physical therapy, diet, chiropractic adjustment is what people need in order to stave off disease if it runs in your family, and possibly avoid it completely if they've got that kind of body that is going to go down the healthy route.
So Dr. Michael mentioned earlier about the different tools that chiropractors have. So like you, as an orthopedic spine surgeon, are all about minimally invasive surgery. Chiropractors are not all about twisting and cracking and that whole popping and thing that a lot of people are scared of, that whole like Jean-Claude Van Damme thing. We have certain tools that we can use, from the time that from an infant to elderly with severe osteoporosis, there's different procedures and tools that chiropractors have. This is one of them right here. This is called a chiropractic activator. What it does is basically puts a little force into the bone from no pressure, and we can do it all the way to a whole bunch of pressure that helps with relieve the muscle strain and as well as actual move the bones. So chiropractic is not all about that twisting and cracking things. There's tools that we can use that are minimally invasive as well. So people don't have to be scared, oh, I don't want to go to a chiropractor because I don't want my neck twisted. There are things that we do, just like you are a master in your field. There's ways that we've mastered and extra training that we've done to do different types of techniques as well in chiropractic.
And there's no reason not to have multiple tools in your bag, right? Because when someone comes to you, you may, hope to do minimally invasive surgery, but there's a time when they need the rods and
You
screws.
simply can't,
You just
yeah.
can't do it. You need full reconstruction. And for us as well, we want to have as many tools in our bag as possible and be able to know and perform the right thing for the right patient at the time. And so, you know, there's people who specialize in only do one little thing, and there's other people that have a few tools. And if they don't, it's really nice to have a network of people to be able to refer to one way or the other. But I personally try to have a bunch of tools in my bag and a bunch of places to refer to as well, so that I can be a good source for someone to trust with their care. That if I can't help them, I'll make sure to let them know where they can go, and if I can, we'll do something. If that's not effective, we can try something else.
What are some of the varieties of manipulations that you guys can offer to people?
And so there are, like we said, there's some instruments which are a lot lighter force. There's some tables that we can use. We use the table that actually it clicks up and it drops down. Think of it kind of like if someone's in a car accident and they're not buckled up. The car stops, the person keeps flying. We have the table that clicks up, drops down, so the body stops, but we can keep certain bones moving in certain directions and line of drives that we want to place them in. And so we can do that with the neck or the cervical area. And I know you're a specialist in that. You deal with that a lot.
Yeah, there's upper cervical specific techniques that my technique that I use in my office, I actually take 3 x-rays of just your atlas. That's the first cervical vertebra in your spine, one from the side, one from the front, one straight down the back. So I basically get a 3D view of how that bone's misaligned. So I put it back with that drop table that Dr. Adams said, with the right line of drive, the correct torque, and the right position to make sure that bone's put back in the proper position. So there's that. You can get a special training in just that upper cervical, just that one bone. There's techniques just to address that one issue.
We have other different instruments, machines. We have a flexion extraction in our office also, where the table will come down, it will stretch and open up and distract some of the spinal vertebrae to help pump normal fluid into the disc, get good healthy motion in there as well. And so really, there's literally dozens of different approaches and techniques. There's specific techniques we use for pregnant women to help breech babies turn to their correct position. There's techniques for children. But we want to be well versed in as many as we can, and the ones that we're not, we want to make sure we know people to refer out to, whether it's our specialty or even other chiropractic or even orthopedists, neurosurgeons. So thank you very much for joining us today. Again, this is Dr. Michael Kapsikavathis, a spine surgeon out of Birmingham, Michigan, and I'm your host, Dr. Adam Rodnick out of Commerce Township, Michigan.
And I'm your co-host, Dr. Ruvain Rubinstein out of Troy, Michigan.
We will see you next time on Ask the Chiropractor. Thanks for joining us.